It's a very hard talk. I thank very much for the organizing committee for addressing these topics. And we will talk about the new molecules of hemodialysis and the effect on the outcome of clinic. So our agenda, we have 5 main topics. After introduction, antiuremic toxins, flux, molecules in the radar, and current and approaching hemodialysis therapy. Dialysis treatment is rising at a relatively constant rate of about globally 6% and expected to around 5 million in 2025. And we should have a hemodialysis modalities that improve the patient's outcome. And are we ready for that? From the current achievements of hemodialysis and survival, and we have to develop to 2025 initiative a hemodialysis practice that meet all the patient needs and to improve the outcome. Unfortunately, we have high mortality, approaching 25% in incident dialysis patients in first year, and this is increasing up to 60% in 5 years. So we are not doing well dialysis. Even in cancer patients, we have either in women or in men, much of the cancer patients survive more. So we don't have quality incentive programs for initiation and maintenance hemodialysis. In addition to that, we have to approach at least 10 points to have a good dialysis, including adequacy, vascular access, infection, hospitalization, blood transfusion, controlling the hypercalcemia, mineral bone disease, phosphate, anemia, pain assessment. All our interest as a nephrologist in adequacy and the vascular access, while the patient's main problem is the pain, clinical depression, and withdrawal from hemodialysis. We should focus as well in the psychology of patient management. Simulations of evaluation of multiple risk factors can decrease the mortality by adding many other factors to improve the healthcare outcome. Individualized hemodialysis treatment, residual kidney function as important as in dialysis, so we have to keep the patient with a good residual kidney function. Using high flux biocompatible membranes, using ultra pure water, online hemodiafiltration in specific patients may improve the patient's health care and preserve the residual kidney function as well. Also, liberalizing the diet of patients. All of us are restricting patients' diet, including vegetables, fruits, in particular phosphorus. And in recent publications this month, does an apple each day keep the mortality away? Looking for the vegetables and fruits, bacteria flora can change the outcome of healthcare patients. And adequacy of dialysis, as usual, is not adequacy of patient care. So we have adequacy of dialysis far away from the patient care and outcome. So quality of life, caregivers, burden, individual patient value, and preferences are required in consideration. Frailty as well is very important because it increases the mortality by 1.6%. And frailty due to impaired clearance of pro-inflammatory cytokines, accumulation of toxins, increased level of additional cytokines, fluid overload. Endotoxemia. All patients have endotoxemia, and this is amplifier of endotoxins. So, about the first part of my talk, so dialysis should be optimal, not just adequate, and we have to look for 2025 initiatives in order to achieve a 5 million patients rapidly growing during the next 6 to 7 years. The major barriers for an optimal hemodialysis: number one, intermittency of the therapy, 3 times per week, inadequate knowledge of solids, toxins, combined water and toxin. Hemodialysis is blind, removing the good and the bad at the same time. Intermittency has bad effect on long interdilated period, volume and toxins accumulation, as well as hyperkalemia. The uremic toxins, number one is the water. Water toxicity, volume overload, left ventricular hypertrophy, as well as rapid ultrafiltration can induce organ stunning. And the vicious circle of intradiabetic hypotension carry more risk for the patient. And myocardial stunning is a well-known damage of the heart, as well as others like intestines and brain, or can be vulnerable for stunning and decreased blood flow during dialysis. Hemodialysis facility practice as well, relating to the management of fluid volume, published this month. Accordingly, we have to develop and initiate a dry weight assessment protocol for each unit, looking for the dry weight assessment, which can decrease all the cause of mortality. Clinical, then additional tools. If you are measuring our dry weight by routine orthostatic blood pressure alone, you can decrease the mortality. If you have a bioimpedance, this is not affecting the outcome without the clinical background. So the unfolding story of uremia with new retention molecules considered responsible for specific clinical outcome. There is increasing interest in uremic toxin publication all over the years, and the uremic toxin assessment is very complex. From the organic compounds, chemical structure, and the composition, accurate classification is very difficult, and the potential toxicity remains unproven. So we have a novel approach is needed to identify and explain their disease correlation. The four main players for uremic toxin to be identified as toxin, you need to measure to be high in patients against control, then should clearly identify that toxin as a disease specific, and the disease should be improved by their removal. Here is a difficulty. And according to the EOTX parameters and identification, we have only 130. However, advances in chromatography and spectrometry, as well as omics, it's expected to be more than 500, and different solid will have different disease effect. How to decrease concentration? Lastly is the diets. We have to modify the diet, reducing generation in the gut, preservation of the kidney function, and lastly the diets. Clinical and applied classification of uremic toxin could be applied as its a chemical structure, or uremic compound produced in intestine, uremic compounds related to endothelial damage, uremic compounds involved in the acute phase, as well in the metabolic source. So you can modify the traditional classification of uremic toxin from the size of molecular weight to more broad classification according to the source or the disease specific. There is always a blind spot in CKD and in uremia where you cannot find everything clear. And this blind spot should be in emissions that we have to remove as much as we can from uremic toxins we know or we don't know. So the difference in dialysis efficiency is very bad and is still unresolved problem in the protein pound uremic toxins, and the protein pound uremic toxin is closely related to inflammation and vascular injury. No dialysis modality had been proved to be effective in removal of uremic toxins, and the reduction ratio is very, very low and unsuccessful with the current technique. Solid flux and the kinetics. Hemodialysis has two types of flux. Number one is the hemodialysis modality, and this is out of the scope of this talk. Dialysis membrane and dialysis time, and cellular flux, which means kinetic modeling and cellular generation. If you look for the molecular weight of uremic toxins and its removal by dialysis, you can find that diffusion by low flux can remove up to only 5,000 of uremic solids, while you need in a high filtration rate in convection, and you to remove more uremic toxin in larger. So dialysis with low flux seems to be obsolete. It's like a teabag effect, just a concentration from high concentration to a low concentration of the dialysis. So it should be obsolete because the removal of uremic toxin is usually unsuccessful. The compartment's effect in hemodialysis is important. The degree of compartmentalization, intracellular, extracellular, number of compartments, as well as the size of compartment. Dialysis time should be as long as possible to move the solids from one compartment to another compartment. If you look for these three partitions, you can find cellular, interstitium, and the dialyzer. So if you remove toxins from the dialyzer alone, you need very long time to move the solids from the cellular part to the intravascular part, then to remove. Here is the importance of time. And time is usually needed in dialysis to move in particular solids from the cell membrane to the endothelium than for dialysis. If you have a short time dialysis, you can remove solids, small solids, but if you have more prolonged time, you can remove middle molecules efficiently. Looking for the retention solids from 10 to 100 molecules are retained in the blood, and this is in different molecular weight. Its retention in individualized patients is important, and how much we can remove by the reduction ratio. And the reduction ratio is very important in using dialysis membrane and dialysis time. Looking for a very small solid, but it's difficult to be removed, like potassium, only 2% of potassium is available in the circulation. Potassium main load is intracellular and removed by diffusion. And rebound is very common after 4 hours of dialysis because shift from intracellular to the extracellular component. Whatever the gradient between the plasma and the dialysate, you have a rebound after 6 hours of dialysis. Because potassium is entering inside the cells by the sodium-potassium ATPase, it is not just a diffusion process. And so we need more and more time to reaccommodate the potassium in the circulation. Potassium is linked to mortality, and 16% of patients experiences hyperkalemia before dialysis. Looking for the small solids like urea and creatinine, it's equivalent because it's very small solid, and applying the two kinetic modeling, solid generation and solid removal. Here is the flux index, which means that the flux of solids from the intracellular to the extracellular compartment. Urea is very small, can diffuse rapidly, while potassium is very, very hardly and kept on the cells for a long period of time. The difference between different modalities, 3 times per week, or short daily dialysis, or prolonged dialysis for 8 hours, augments the effect of that, and more time is needed. And the two-pool kinetic modeling for urea and the creatinine is not applied in general for the all solids applied. Looking for the phosphate, hyperphosphatemia is only 1% of the overall phosphate pool. So patient may have hyperphosphatemia or not, but they have at least phosphate load. A third pool of phosphate is very important to be removed, and this takes at least 8 to 10 hours to recalibrating again with the intravascular compartment. So the third pool of phosphate plays a major role in removal, and only the time factor is essential to remove as much as you can from the phosphate. Looking to the beta-2 microglobulin, the godfather of the middle molecules, removal is dependent on convection, and convection time volume is essentially to remove as much as you can from the beta-2 microglobulin, with difference between low and high flux, and you need high convection volume and a high permeable membrane. So additional local environmental factor as well play a role. Uremic crosstalk, it's not only accumulation of toxin, it's as well the accumulation of other environmental factors that augment the effect of a toxin. For example, the phosphate, hyperphosphatemia alone is not like hyperphosphatemia with complex phosphate interactions. Inflammation, acidosis, deficiency of chlorine, or hypercalcemia all augment the phosphate toxicity. And this can affect the phosphate transporters and can induce vascular smooth muscles, cell calcification, and matrix mineralization. So classification and inflammation running together with increased CO2 production, changes in the local pH, changes to the ratio of mono to dihydrophosphate, and this can augment the phosphate influence. Also in beta-2 microglobulin, if you have inflammatory cells infiltrating the synovium, inflammatory cytokines induce receptor activation of nuclear kappa, and so it's not just a simple beta-2 microglobulin deposition. So what is in the new molecule in the radar of hemodialysis? There is a lot of molecules, advanced glycation in the product, mediators of vascular calcification, gut microbiota trimethylamine oxide, light chain, cytokines, and asymmetrical dimethylarginine. All these are hardly removed during conventional hemodialysis. There is a great interest in vascular calcification and mediators, and the concept has been changed to be removing of about 55 Dalton, which is nearly more than triple size of the beta-2 microglobulin. Free light chain, complement factor D, and you need a higher permeability membrane to be removed. Here is our goal, beta-2 microglobulin, light chains and others in the range of 50 to 55 molecular weight, just below the albumin target. Using the omics, and the omics is a perspective for identifying and quantifying the uremic toxins by using different techniques, genomics, epigenomics, proteomics, glycomics, and the metabolomics, all are identifying uremic toxins according to DNA, RNA, proteins, and biochemical or biological phenotype. Example of that, you can develop a biomarkers of a known uremic toxin could be related to cardiovascular or CKD, MBD. Proteomics is well known in hemodialysis field to induce molecular definition, identification of prognostic markers, disease-specific toxins, and blood purification efficacy. Proteomics have been shown differences between low flux and high flux dialysis, and the identification of middle molecules using proteomics in the dialysate span. So there is not currently removed in the radar of hemodialysis more than 25 Dalton, kilodalton of uremic solids are held in the patient and need to have an attention for that. In particularly, the inflammatory cytokines, adipokines, immune mediators, and growth factors. Uremic compounds related to endothelium, we have 4 killers: atherosclerosis, vascular calcifications. Abnormality of vascular calcification is important. It will be on details later. And vascular smooth muscle cells, phenotypic changes is important. So we have leukocyte activation, endothelial adhesion, migration, thrombosis. Trimethylamine is only as well known toxins emerging for 2 years, correlated badly with the CKD stages and in dialysis, available in beef and veal, chicken livers, and some fish. And it's also in the red meat, coming from the choline and the L-carnitine. And trimethylamine oxidase had been focused on macrophage, vascular inflammation, and platelet activation. It's hardly removed during dialysis. It's 75 kilodalton. So it's very big and is poorly correlated with dialysis urea clearance. As well as symmetric dimethylarginine in the focus, it's a small molecules and potent inhibitor of nitric oxide synthetase and is directly related to endothelial damage. Lastly, what we have right now, current and the future, we don't have too much. We have current techniques to overcome the retention of solids, molecular weight, and low molecular proteins. We have high flux hemodialysis, hemodiafiltration, as well extended and expanded hemodialysis. Exploring that by dialysis membrane, we have high flux, and the medium cutoff needs more clinical trials, removing as much as 50 Dalton of uremic toxins, and successful practice has been growing for hemodiafiltration, but we have problems in the logistics, regulatory, economic, technical, vascular access type, and the high substitution volume is needed. Also, effective anticoagulation is important, and water purity is paramount. Removing molecules with high convection volume is associated with albumin loss. Needs more and more clinical trial on the nutritional elements. We have published this year for the DNA methylation effect of hemodiafiltration and very successful in genetics. And expanded hemodialysis is growing, needs specific patient with low vascular access. And lastly, in conclusion, there's increasing demands to optimize hemodialysis, and the current achievement is still unsuccessful, and more molecules to target could be step forward for the future. Just to announce it's a mission to have a hemodialysis education program for a better outcome, and we will have a spring course of hemodialysis, and thank you very much.